Endoleak is a very common complication after EVAR. It's reported in up to 50% of endovascular repairs. In the two major trials, FDA trials that were done in the United States, there was a 30% endoleak across all time points. This is defined as flow outside the endograft but within the residual aneurysm sac and exposes the aneurysm to continued hemodynamic stress that would lead to potential expansion with the risk of rupture. It's most commonly originating from residual branch vessels, type 2, like the lumbars and the IMA. All of these references document that we can find endoleak in up to 50% of patients following EVAR. The protocol for looking for endoleak is to use B-mode. There are a lot of clues with B-mode that can tell you where to look for endoleak. We're of course going to use color flow within the graft and within the residual aneurysm sac, looking at all potential leak sites. So if any attachment or fixation site or a modular connection sites where the IMA would normally come in, and looking for lumbars. And then that has to be confirmed with spectral Doppler, because there can be some very convincing looking color flow that isn't truly a leak, and you have to confirm that with spectral Doppler. If you're scanning and you see B-mode clues and you've got a real strong suspicion that there's an endoleak and you're not able to identify it really easily, reposition the patient to a flank position, rescan in those suspected areas, and you may be more successful. We're going to look also in B-mode for several things. We're going to look at the attachment sites so you can see where the device begins and ends. Here's an inferior. You can see that strut structure quite nicely. We're also going to look at the B-mode appearance of the residual aneurysm sac. We know that normally thrombus is homogeneous, and here you see this little hypoechoic area. I would really strongly investigate that for a leak area. If you ever see in an unsupported graft wall motion during the cardiac cycle, that means that there's more pressure out here outside the graft in certain portions of the cardiac cycle than within the graft, and that's almost always associated with an endoleak, graft deformation that looks like this during certain portions of the cardiac cycle. The other thing that we published about in 2005 was the appearance of a spongy-like texture to this thrombus within the residual aneurysm sac. This was usually associated in a small series of patients with very pressurized sac and very low flow endoleak that created aneurysm expansion of up to a ½ centimeter a year. So it was significant aneurysm expansion associated with this particular B-mode characteristic. So here are some examples of those spongy sacs that were likely to lead to aneurysm expansion, and you can see that they are very heterogeneous and almost have this sort of thread of flow going through wherever it can kind of seep in around the thrombus. And these were the ones that did result in significant aneurysm expansion. When we're looking with color, we want to use real-time color flow that will identify the source of the endoleak and the flow direction. Your PRF has got to be set very, very low, your wall filters low, your gain set high, because sometimes these are very low flow states. So you really need to optimize your system for that. Then you confirm the spectral waveform of that endoleak and make sure it's not an artifact. We do know that some of these very small leaks can cause systemic pressure within the residual aneurysm sac, and we know that from direct pressure measurements at the time of explantation from some of these patients. The color sensitivity should be very high, and we're going to image slowly from proximal to distal, from one attachment site to the other, optimizing for looking for endoleak and looking at the thrombus and making sure that that is a thrombosed site. We need to be aware of those potential sites of perigraft leak. A true leak will have usually different arterial waveform characteristics than that of what's in the graft, unless the graft is what the origin of the leak is. This is an example of a biphasic flow. In general, biphasic flow is associated with something that has an inflow and an outflow, whereas the bidirectional flow, as you see in this picture, is associated with something more similar to the waveform characteristics of a pseudoaneurysm, where there's flow in systole and drags back out in diastole. That's usually representative of a leak that only has one source. Occasionally we'll see two colors within the limbs like this, and you think, well, these are supposed to be going in the same direction. Why are they in two colors? Well, frequently they will cross the limbs, and you will see one of them more angulated, and in the transverse view like this, it's going to appear that it's going in a different direction when it's actually not. So let's talk about the different types of endoleak. We have the anchoring system or attachment site endoleaks, that's type 1. We have the intersegmental junction modular endoleaks, that would be type 3. The most common kind, is, of course, is the branch vessel or type 2 coming from patent lumbars or IMA. And then type 4 is transgraft or through the porosity of the graft fabric. Any of these can cause pressurization of the sac and aneurysm expansion, and we don't know which ones will and which ones won't. Here's examples of these different types of endoleak. Here is a superior attachment endoleak. Here is an IMA endoleak. Here's a lumbar endoleak with that 2-fro flow. This is an inferior attachment leak, and we need to look for all of these. This is a type 1 or a distal attachment leak. There was not a good seal due to calcific plaque at the distal common iliac. And here you can see flow going towards the foot, depicted here in sort of a pink-red color, and then back up towards the aneurysm sac, adjacent in this iliac artery in blue. You can see retrograde flow. Because this was originating from the graft itself, it had the same waveform characteristics of the graft and was biphasic. This is that patient that had the superior attachment leak, and if you look here you can see that not only was it leaking there at the superior attachment and scooting up adjacent to the device, but it actually was feeding the existing IMA in the correct direction, going out into the periphery there. This is a type 1 endoleak from the inferior attachment. Here you can see it on angiogram, CT, as well as on duplex. This is a typical type 2 endoleak. Here is a whole nest of lumbars that were patent. You can see it's causing a large endoleak in between the 2 limbs of this graft, and this is about a month later a 3D reconstruction CT was done depicting the same type of endoleak. No modality is going to miss a very large IMA leak such as this one. This one is very easy to see. You can see that it's causing some movement of the graft wall right here. This much more subtle, smaller lumbar leak is the one that is much more difficult to define and look for, and takes a bit of skill to do. Here's another IMA that has sort of a bizarre flow pattern entering the aneurysm sac. This is an example of the lumbar where you see in both longitudinal, transverse, and you can see that lumbar feeding the posterior portion of the sac, as well as the bidirectional flow confirmed on spectral Doppler. So we have all 3 views that we need to confirm that that endoleak. Type 3 endoleak, this is a disconnect of the modular interface. Here you can see angiographically, and it was causing this big, huge leak you can see on the Doppler here by the color, right where this was disconnected here. Here's another type 3 endoleak seen on CT as well as duplex ultrasound confirmed with spectral Doppler. This is a type 4 before and after a wall graft. I don't think that we will ever be able to tell the difference by ultrasound between type 3 and type 4, but you will know that it's there and suspect that it's not something associated with branch vessels. The pitfalls in endoleak detection is that there's a wide discrepancy in the rates of the endoleak that is detected. Small leaks are often more difficult to define, and we know that leaks more difficult to define in the supported endografts, and all of the available endografts in the United States today that are on the market are supported. So that makes it our job a little bit harder. There are differences in device design and construction that affect our ability to detect endoleak, and that's due to wall oscillation and pressure transmission. But we do know that small leaks can cause systemic pressure within the aneurysm sac, so all of them are important until proven otherwise. There may be a role for ultrasound contrast, although this is an off-label use. We used it in our center to help us to identify those patients in whom we thought duplex said there was endoleak and CT was negative, and the ultrasound contrast confirmed those that were positive really for endoleak. So let's leave endoleak for a moment and talk just briefly about limb dysfunction. Unsupported endografts are more at risk for limb dysfunction, and even though there are no more of those on the market, there's quite a few patients out there with unsupported limbs from the AnCure device. we can effectively identify any problem that is going to threaten the graft patency: twisting, kinking, bending, tortuous iliacs, incomplete deployment occlusion, and aneurysm remodeling over time. So here's an example of limb dysfunction early on. Here is a stenosis. You can see a high velocity. This was early in our experience, was reballooned, and we have a nice normal triphasic flow. When we talk about aneurysm remodeling, when these aneurysms start to shrink, they shrink, and sometimes this happened to be a uni-iliac graft, and it became very redundant and kinked on several occasions. And you can see here angiographically how kinked that was. And remember, if this is an aorta uni-iliac, it's supplying both limbs. So this is a real problem. But over time, the morphology of that residual aneurysm sac can change, and if that graft becomes redundant, then this has to be addressed. This is what we don't want to see. This is an endograft occlusion in this limb. And here's an example where you see that this limb, the right limb, is flattened, occluded, and very different in appearance from the circular, normal left patent limb. So the advantages of duplex ultrasound after endovascular aortic repair is that we can provide very accurate residual diameter measurements of the aneurysm sac. We can be very sensitive to endoleak detection, identifying the source of it, the direction of flow. We can evaluate limb dysfunction, any other hemodynamic impairment that might threaten the graft. It's relatively inexpensive, reproducible, and does not require any contrast. And I believe there's an additive effect of CT and ultrasound and follow-up of these patients. The disadvantages is that it does take a time commitment. It usually takes about an hour or so to do these studies thoroughly. It is a technically challenging study. However, with proper training and desire, most labs or facilities can do this well. You do need high resolution or the more expensive type of equipment because you need something with very robust spectral and color Doppler. But the hardest thing, I think, and the biggest disadvantage is that making patients understand that they are committing to lifelong follow-up and compliance with that follow-up so that we can identify any complications that may occur over time. Thank you.